ones. But one thing kind of going back to that eval as well, or initial treatment, is
Mhm.
I'm going to try and think of the joint in different planes as well. So I'm going to try and demand things on that joint. And that if you can think, I'm thinking more specifically hip here, just for example wise, I'm thinking what attaches onto that joint. So what structures might be taut, what structures might be inhibited, um, and what can I do to recruit those inhibited ones? What can I do to elongate or downregulate some of those overactive ones or the ones that are untensioned? So sometimes it's a rotational point to the hip. Sometimes it's working it sagittally. Sometimes it's frontally. So I think that that's one thing. You can keep it simple in that realm to where, have I been doing everything sagittal with them? Okay, maybe I can move on to something frontal or rotational. So it's not making everything that easy to where it's like, okay, I did sagittal, frontal, transverse. It's how can I attack this joint differently, and what can I do to change the demands of all the structures that go around it.
Yeah, I I want to. I have a statement of my own, but I want to follow up on that. Do you always do sagittal prior to frontal? Is there a scenario when you would do frontal before a sagittal and or transverse, for instance?
Now I'll jump around a bit. Um, so, and I've had this talk with people before. I'll jump around. I think that sagittal plane is sometimes the easiest one or the lower hanging fruit for someone to be able to get a hold of, right?
Is there
So,
such thing as a sagittal plane?
but
Is there such thing as a sagittal plane?
according to you, maybe not. But again, for the sake of keeping things simple, we can visualize the sagittal plane. Um, no, I think that it doesn't have to be that strict. There's definitely gonna be times where if you neglect a certain plane, you're
Mhm.
you're basically being unrealistic with A, how that joint functions, and B, how it can be more resilient. Like the body's not that robotic where you have to go step by step in my world.
Yeah, I do agree. Like there's an instance where someone could benefit from frontal and get faster results than attacking sagittal only. Um, so I guess going back to like evaluation, what I had in my mind kind of start this conversation was, I guess I'll just go over a couple things in my mind, and you can just let me know your thoughts. If it seems feasible to do, if you do it as well, or do some to some degree. So, for instance, I just figured out or guessed my best guess of what the issue is, and so from there, in order to guide my exercise selection now, I'll look more at probably the first thing I'll look at is infrasternal angle, just kind of get an idea of what their body type is. And then from there, I want to figure out which way their pelvis, for instance, could be facing and which way maybe their spine as well. So which way both those are biased to. And so that'll give me an idea of, okay, I have an exercise selection for a wide versus a narrow. So now in my mind, I know a couple of different positions per each one that I'm going to lean towards, as well as what do they need to get them back to, quote unquote neutral or more neutrality. And so I guess a more starting point. And so from there, I know, okay, I'd have to derotate a hip to the left and maybe a trunk to the right. And so I know, okay, I'll need, left abs to get the trunk. I'll need a left adductor, left hamstring, a left. I mean, we can talk about this for a while, but just to shift me back to my left side, get more of that, I guess, pattern. And so that's kind of what I look at to start. And I guess it can be hard because if I look at like a shoulder, for instance, I know, okay, we talked about like what kind of motion do they have, what motion bothers them. To an extent, I may not even touch the shoulder to start. And so it may just be an exercise where he's a wide, and I know I want to get him in like maybe a 90-90 supine position and just kind of start there and see if symptoms are decreased, if they're continued, whatever it might be, and just kind of base it off of that and just tricky too, because like we're talking about a process. So is my process always going to be to do manual therapy to start with? Maybe I don't know. So I think I'd have to see what the patient would respond to, and so like for instance, like going off FR, there's really only one, right? There's mechanical. Trying to think, there's only one reason, basically one or two reasons why you would use manual therapy, and I don't think tone was one. I think it was. Do you remember what I'm trying to get at?
Mm-hmm.
I forget, but it was basically like you can't really use sensitivity. You can't use feeling like a nodule of whatever you're feeling, whatever that is, if it's fat deposit or if it's an adhesion. So there aren't too many reasons basically warranting manual therapy. And so I don't know. It's hard. Like just talking out loud, I can tell this is a blind spot because it's like for me, like, okay, what tells me I want to do manual therapy as opposed to just doing it every single time to start. And then exercise. Like exercise is what really gonna probably be my main mover, but the manual therapy might be just a like a noxious stimulus to allow me to begin that movement, maybe that pain-free movement, or allow me to begin exercise. I guess what tells you. I know, like I feel like you're the same way, where you're biased towards doing manual therapy. Like it's fun doing it. You get quick results, but what is physically telling you that someone needs manual therapy?
You know, I this is one of those things where I've looked at research articles, and sometimes that's tricky because either they're going to tell you what they're looking for, and you have to kind of read through the deception, if that doesn't sound bad, but
Mm-hmm.
you have to understand that it is a personal type of relationship as far as treating an athlete. And so you're not going to put all your eggs in the basket of, okay, I treat him manually and then send him on his way. But there is a value regardless of what research says about there's not really a tissue change. There's not all these promises or anticipations that we're thinking that we get with manual therapy, but that there is sort of like an intimate kind of bond that you get with the patient to where they feel like if they have their hands, someone's hands on them, and they're feeling through the tissue, that if it is some sort of placebo type response, that is some sort of a win. um, so in my opinion, that is a part of it. The other part is also I'm kind of getting a feel. It's another way of looking at the range of motion as well, feeling where there is some tautness, where is some of that restriction coming from. So just paying attention. I'm not going through manual therapy and kind of just uh, what would you call it, spacing out, just thinking nothing, and I'm paying attention while I'm feeling through that. And again, it's part of that eval. It's also a time for me to buy time and think of what I want to do movement wise, because I think the big win is what you get movement wise. So
Yeah.
I'm basically I'm setting the table when I'm doing manual therapy, and then the main course is the movement, because I think that's really the internal structures of movement, and having muscular influence on those joints. I think that's where you get your big win. Um,
Do you have like a process then for manual therapy of kind of how you view it to like where to start?
I would start locally. I would start locally and work my way out. Um, so I'm gonna again hit those structures that realistically I think are probably going to be involved. I'd be happy to be proved wrong if there is a structure that isn't responding the way I would expect. But I think that you kind of have to address those ones. So for a pitcher with the shoulder, the cuff is probably going to be a big point that you're going to want to at least pay attention to. Work your way around that. Look at pec, look at big movers, lat, subscap. But I would hit those first, and kind of get some feedback, and see, do they get more horizontal abduction after working on the pec? Does that matter? How am I going to drive it home? If I do get this new range, what am I going to do to make that stick? Because it's mostly transient, really. And as a wise man once told me, it's non-specific neuromodulation. but but I don't know that we're specifically hitting that muscle and making that muscle longer, like you said? Are we working on tone really, or is it basically just either getting them to calm down? Is it
Mhm.
getting a new input different than the nociception that they had? So whatever the reason is, again, boil it down, make it simple, and the more we try and complicate things and get way deep into the rabbit holes of um, why is this manual therapy doing what it's doing and why that is valuable, but at the same time develop that system first and pay attention to how they're responding in order to get the results that either you want or to get results in general. And just pay attention to what happens really.
Yeah. At the end of the day, all that matters is the outcome, right? And if the outcome is favorable, I would say you did a good treatment. And you could have just slapped them in the face and they forgot about their shoulder pain. That's still a favorable outcome. Probably not the best route, but yeah. And so, like for me, I'm trying to think out loud. If someone comes in, I'll actually use a scenario. So, player came in, had bicep or the bicep. All testing showed um, bicep issue, just kind of a little nodule, maybe like right up here. And so if you touch it, he'd wince and say, that, "Oh, that was it." Um, I knew if I started right at it, and I think and that's okay. That's another good part too. Is doing it's twofold. So basically, getting your hands on somebody and touching the spot not only acknowledges to the athlete or to the patient that I'm aware of where you're feeling it. I'm aware that it's here, but you're also getting your hands on them and you're little as Pete's joke is serotonin. Let's give you some
We have
serotonin.
to get them on here soon.
Yeah, we do. But besides that, I think it's good. Like it does give you an idea of okay, I'm gonna try and do some things to maybe get them out of pain right away, and at the same time buy myself some time to think about what am I going to get out of this evaluation? What exercises should I do, or at least what direction should I go? Um, and so, for instance, the bicep. If I touched that area, was for him just felt at ease. I just felt like whatever I felt feeling was just taut and that elicited pain. And so I didn't hit that first. I just, you know, played around with his shoulders, kind of like a fake eval, just seeing what I had. And the dude has zero external rotation, and that could be it. You know what I mean? Like that is definitely not something I'd see as 80 degrees of ER. Probably needs more. Can't say for sure that was it, but I was feeling I was okay. And then I started thinking, okay, what are some things to gain more ER, or what are some things structures if it's a bicep, like an anterior line if we're using like anatomy trains. And so I kind of combined to start with. I kind of combined some Steco stuff with anatomy trains and just search for like in the hand and the thumb, then the forearm a little bit. And then I worked more in the like bicipital groove area. And so I checked those spots first, and then went back and rechecked the bicep. It was decreased, wasn't gone, but slightly decreased. And so I was like, okay, well, how can I improve some shoulder ER? And so I did one or two like FDM spots, like basically in the neck, like supraclavicular spots. Hit that, rechecked. ER, felt a little smoother, and from what I could feel, him he couldn't really tell, but he said the bicep itself felt a little looser. And so going back to what are basically like being able to change and being able to like stay fluid. And so feeling that he had not as much ER, but the bicep pain was still kind of there. Okay, in my mind, what gets external rotation? So like you could hit anything on the front side that limits ER. But I knew that in order to get ER, you have to expand in a certain area in your back. So I was able to do some like manual therapy scat moves and try and facilitate some airflow, basically in T4 to T8 area. And after we did a couple sets of those, that got some ER back. Wasn't much. It just felt a little smooth to get to the end range. He said that the bicep pain he felt wasn't as tender to touch anymore. And so also was a combination of just getting him to breathe. I think that was a huge down regulator as well. So whether it was strictly that or the fact that I just got his scap moving a little bit, or at least helped his scap move and maybe some proprioception of, hey, this is what a abducted scap feels like. This is what an adducted scap feels like. And so I started with that. After that, I ended with hitting that spot. He had 2 days off, so just put the elbow down and went to town on that bicep spot. Afterwards, he said he felt good. Said it was definitely way down in pain wise. So we'll reevaluate this week. But even just thinking out loud, I was like, I feel like I hit. It wasn't as processed, I think, as I would like it to be. It was kind of, I'll hit some like anterior line stuff because it showed an anterior line, quote unquote, um, symptom. And so I hit those, and then stuff that I dialed more into what limits ER. I didn't really hit pec too much. I didn't hit pec, didn't hit pec minor. Did not hit lat. And I think for him, I think exercise is going to be his key. But just thinking out loud, like I don't know if there was a full process. A couple of them would probably just, I'm just going to try and hit this and hit this. But it was almost throwing too many, like, not saying too many techniques, but each technique is a tool. And so I think if I had a better process to say, I want to do, if I'm doing manual therapy, my aim, number one, is to do X, and then X, Y, Z, just trying to like have a fluid model for doing manual therapy. I think that's something I need to work on.